Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney and today I'm joined by our guest Belinda Matthews. Now Belinda is a physiotherapist. She has a wide physiotherapy experience. She's honed a special interest in women's health, particularly management of incontinence, and that's what we've got Belinda here today to talk to us. It's really special for me because Belinda actually works with us at our Ballarat Women's Clinic. So a big welcome, Belinda.
Thanks, Brigid. It's really special to be here with you.
Yeah, and we drove out in a very foggy morning, didn't we?
Typical for Ballarat, I think, at this time of year.
Yeah, it was just so weird. Anyway, Belinda, I love what you do in the incontinence space. I mean, you're so passionate about it. So it's a thrill for our listeners today to have someone with such great experience. So thanks for taking the time out of your busy week. So as a physiotherapist who works with women, I thought it might be really great, because it surprised me when we had our initial chat, about what you expect good continence to look like.
So good continence, when we're talking about the bladder, is being able to hold urine in the bladder until there's an appropriate time or place to actually empty the bladder.
And when we were talking, I said that I felt like it was normal for me to get up at 4 a.m. in the morning to go to the toilet. But you said, no, continence means that perhaps you should be able to hold your bladder all night. Is that right?
I think there's a few factors that come into it, but if we're weeing before we go to bed and we're sleeping through the night, then we anticipate that our bladder is not waking us up. As we age, we do tend to find that we may need to get up through the night to wee, but I suppose when we're looking at our demographic of ladies having babies, so coming into pregnancy, we shouldn't really be waking up through the night to wee.
Yeah, we'll talk about when you're pregnant, because I'm sure that all changes. And incontinence just isn't urine, is it?
No, so we can have incontinence from the bladder, or we can have incontinence from the bowel as well, which we'd call fecal incontinence.
All right, so let's talk about incontinence. What do you see as, what would you class as someone having incontinence?
So back to, I suppose, our definition is that wee is escaping from the bladder when we don't want it to. So it might be unexpected, or we're not able to hold it in when we want to.
And sometimes that's when we cough or sneeze, or if it's in my case, every time I run to the door of my home, I just can't quite get the key in the lock.
Yeah. So now we're talking about the types of incontinence. So we can have incontinence from a stress, a pressure, a load, which is like the cough or the sneeze or the jump or the run. And then we can also leak from what we call urge incontinence. So that's where the bladder muscle itself, that muscle's called the detrusor, it's actually squeezing before we actually can sit on the toilet to wee. So that muscle squeezes, that's how we do empty our bladder when we wee. So there's a lot of factors that can come into why someone might have urge incontinence, but certainly as we age, some of our behaviours, they can influence when that detrusor muscle's contracting.
And what about fecal incontinence? What are the signs and symptoms of that?
So fecal incontinence, if we talk of both the loss of fecal matter, or we're talking about the loss of wind as well. So if we're not able to hold wind in, so we might be bending over, or we might be having a laugh as well, or lifting something, then that also we would call incontinence as well.
And what about the times, like, I mean, I hope I'm not the only person here who's listening to this podcast where you've accidentally done a little pop when you've been, say, at the yoga class. It may or may not have happened to me, but, you know.
So it is a form of incontinence, and we'd call that flatal incontinence, not being able to keep the wind in during activity, or when we're doing things that we don't feel it's socially appropriate to let go of that wind.
Yeah, right. Even if you've got like, I'm sure he won't mind me bringing this up, but one of our, I call him our fifth son, he would spend a lot of time at our house. And at one time, he accidentally did a fart at the dinner table while we're all sitting down eating dinner. He bent over to pick something up off the floor. I mean, it was just such a big laugh, as fart jokes are in a household full of boys. But is that just a one-off, or is that a sign of?
Well, I suppose when we're looking at children, if we're talking about being your fifth son, it'll be looking at more of what the underlying factors are with that. I think as we age, different things have occurred, whether we've had pregnancies, whether we've had deliveries of babies, and how the pelvic floor is functioning at that point. I think in children, that's probably another whole discussion.
Yeah, we might have that discussion offline. So maybe if we start talking about like how common it is, and I know that you can't just say a blanket, this is this common, because we're talking about people who are pre-pregnant, pregnant and postpartum. So how common is incontinence?
Yeah, so statistically wise, if women have had a baby, there's a 1 in 3 chance that they will have had incontinence in their lifetime.
Wow.
So that's pretty high.
And we'll get into pregnancy, but I just quickly want to ask if it matters the type of delivery that you've had.
So certainly vaginal delivery does put us at more risk of urinary incontinence.
All right, I don't want people to despair about that. I'm sure there's things that we can do.
Absolutely,
and
there
we'll talk about that. I wonder whether there's just an overall lack of knowledge about the pelvic floor. Maybe if we talk a little bit about the anatomy.
Yeah, so I suppose, is there a lack of awareness? I think definitely in the age and stage we're at now, that is building. There's a lot more knowledge around that for sure. And as you said, I think we'll come back to that. When we think about the pelvic floor muscle itself, it's a collection of different muscle fibres that are bound by connective tissue, which is that fibrous type tissue. And it's filling in the whole bowl or outlet of the pelvis, and then it has the openings for the bladder, the bowel and the vagina. So it's got amazing functions for the bladder, the bowel, vagina for sexual health and support of all the organs above it. So it really does have a big job to do.
Yeah, massive. And when you say the different fibres, say somebody's got something like hypermobility or elastanus or something, are they more prone to having problems with their pelvic floor?
They are, because we're now talking about the connective tissue, the fascia that is part of that pelvic floor network, but we're also talking about that fascia that's surrounding the organs, the bladder, the bowel, the vaginal walls, and the integrity of that over time to support those organs, but also provide support to the bladder neck and the urethra, which is the exit points for the wee.
Okay. And we often think about the pelvic floor as it being weak. You know, we see that in some of the media that we might consume. But there's also an overactive pelvic floor. And I wondered if you could tell our audience about that.
So an overactive pelvic floor is perhaps a broad term that we would use to describe a muscle that does not have good coordination and is not able to relax at a time that we're perhaps at rest. And there's lots of reasons why that pelvic floor might be overactive. And just going back to, say, that hypermobility, we might have a muscle that's working much harder to support that area. It can be associated with pain, so whether that's from trauma or endometriosis. There's people who perhaps exercise at high levels are more likely to have an overactive pelvic floor. And there's certainly a link as well to anxiety and perhaps a history of trauma in some way as well.
And when we talk about, you know, doing something proactive for our pelvic floor, we do talk about pelvic floor exercises. I just wondered, if you've got an overactive pelvic floor, 2 things. What would you do, in terms of your exercises? Because I'm imagining you don't need to contract that anymore. But how would you know in the first place?
Yeah, so I suppose we look again at the functions of the pelvic floor, and we might be getting symptoms from the bladder, the bowel, vagina as well. So from a bladder, we might find that we're not fully emptying. The outlet is not relaxing well to allow fully emptying. We might find we also have more urgency. So our bladder's asking us to go more frequently or more intensely to go. We might have pain with examinations, pain with intercourse. Then when we think about the bowel, we might have difficulty emptying as well, which might sort of set up a cycle of constipation. We might have pain in the area, so we could have low abdominal pain. We might have back pain. We might have tailbone pain. Sometimes we can get sort of shooting pains in that area as well. So they might be some of the symptoms that someone has. We can have those symptoms from other things as well. So if you're unsure, that's perhaps when you're seeking help as well.
And for those that perhaps have a diagnosis of something like endometriosis, they would already know whether they had a overactive pelvic floor, would they? Or
they may not realise that some of those symptoms are because of their pelvic floor. So they'll certainly be aware they've got symptoms, but perhaps again around their knowledge whether they do actually know they've got an overactive pelvic floor.
It's fascinating. The reason why we wanted to get you on is there's been some more research released about incontinence and particularly in the pre-pregnancy phase. Can you describe what somebody could do in the pre-pregnancy phase to help with their continence as they grow a baby?
Yeah. So I suppose when we're talking about research, it's collective research. It's building that, I suppose, evidence base and knowledge. So what we know is women, say in that first early phase of pregnancy, probably have about a 20% increased risk of urinary incontinence, which increases in that later stage of pregnancy. So we also know that women who strengthen their pelvic floor early in pregnancy have a reduced risk of urinary incontinence during pregnancy, but also postnatal. So I think it's, I suppose, a timely way to then discuss starting pelvic floor exercises early once you know perhaps that you are pregnant, so even in that first trimester, and you don't have to have incontinence to benefit from doing pelvic floor exercises. So those benefits to the risk of urinary incontinence are still there, even if we didn't have incontinence in that early phase. And then if we're really keen, we can start those exercises in preparation for a planned pregnancy as well.
Yeah. And so people who join our program, they get Belinda teaching you about the way to do pelvic floor exercises. But maybe we could give a little hint on what's just a simple thing somebody could be doing if they're pre-pregnant now to look after their pelvic floor.
So I think firstly it's sort of identifying what the pelvic floor feels like, how to actually do that contraction, because if you're going to do the exercises, they're going to benefit you more if you're contracting it correctly. So if we think about, I suppose, the bowl of the pelvis, so I would look at, even in the chair, you could simply rock back and forth. You can feel perhaps the tailbone, the coccyx from behind, and then as you rock forward you can feel the pubic joint, so you've got the muscle running right between those two. And then from side to side, your sit bones. So if you, again, just sway your body a little side to side and feel where those bones are, the pelvic floor's running between those bones, so it's filling in that whole space. So if we're activating the pelvic floor, we can think of, I suppose, two key phrases might be stopping a wee, stopping a wind, and lifting up inside. Okay, so to feel that muscle coming up, but then when we're letting it go, to actually feel that muscle coming down and relaxing as well. So strengthening a pelvic floor, we look at different components of that muscle function. So it might be endurance, where we're able to hold that contraction for a period of time, or speed component of that muscle. So if you cough or sneeze, you want a muscle that can react quickly and respond. So when we're doing that strengthening, we're looking both at endurance type exercises and then those fast-paced sort of contractions as well.
I think when early days for me, it was only about contracting. I never had the second part of that pelvic floor exercise, which was the releasing.
Yeah, it does sometimes get a little bit lost. We do tend to think the pelvic floor, we strengthen it, but good capacity muscle can be used at any range that we require it, whether it's a maximum contraction, a partial contraction, or relaxation when it's not needed.
I've just realised I've been sitting here the whole time with my pelvic floor on. Okay, relax. Good. Excellent. Let's move on to pregnancy now. What in pregnancy changes for the impact on continence or the impact on your pelvic floor?
Sure. So I think the first thing to remember is that we all come to, I suppose, pregnancy with pre-existing weaknesses or stiffnesses and things like that. And the challenges and the demands of pregnancy then may highlight underlying issues as well. So I suppose what changes with pregnancy is initially those hormones increase, so your estrogen and progesterone. So we're getting the capacity of that connective tissue to stretch so that we can grow and have space for that baby to develop. So we've talked about that connective tissue within the pelvic floor muscle, and also supporting the bladder neck and the urethra. So we're starting to get more give in that fascia as well. So then I suppose as the baby's growing, there's more load on that. And then we might find that then a cough or something like that, we are starting to actually leak a little bit of urine at that time.
Are there any other diseases or conditions that can make you more susceptible to incontinence?
Yeah, so we know there's definitely an increased risk with gestational diabetes. We've also sort of mentioned hypermobility as well. Some other risk factors we know with urinary incontinence in pregnancy is if we've had incontinence before, so that might be a previous pregnancy, it might be childhood. We might have had some incontinence then, or we sort of term that enuresis. The number of children that we've had as well, our age, as we age, then we may be more at risk of urinary incontinence. Yeah, and there's a few other links. It might be if we've got lumbopelvic sort of pain, depression, those sorts of things can increase our risk of incontinence in pregnancy.
Fascinating. So gestational diabetes, is it just the hormonal impact of insulin, or is it more to do that, perhaps they're having a bigger baby on board? Or
Well, yeah, that definitely. A larger baby can increase our risk of incontinence. We might, with diabetes, actually produce more urine, so it can be harder to hold that in as well. Yeah.
I love I see your patients that you work with that have urge incontinence and you do the bladder training. Is that something that you can do in pregnancy as well, or you sort of just give up and you just go to the toilet a lot?
Well, I suppose we expect there's going to be some increased frequency with pregnancy because the way we know that we need to have a wee, we've got little pressure receptors in the bladder and, we've got a growing baby sitting on our bladder. So those pressure receptors are going to tell us more frequently that we need to go. I think most of that is going to resolve after you've had the baby, but some of our behaviours can also influence that. So, if we're always having a wee every time we get home, if we're always having a wee before we leave the house, those sort of behaviours over time can perhaps add to that urgency after we've delivered the baby as well.
It's the just in case wee. Yeah. And somebody told me about that ages ago, and I was, like everybody else, the kids are getting in the car or whatever. Everyone have a wee before we get in the car. I've stopped doing that.
Yeah. So we are designed to be able to choose when we go to the toilet, but generally I would say if you know there's a toilet where you're going, if your bladder hasn't asked you to go to the toilet, then just allow it to tell you when it needs to go.
Is emptying a bladder more difficult when you're pregnant? Like, sometimes you when I remember being pregnant and you sort of think, oh, my God, I've got to go to the toilet again. And then it's a dribble and you think, well, that really wasn't worth it. But I'm probably not emptying the bladder in the first place.
Sometimes, yes, it can be more difficult to empty the bladder with pregnancy, but it might also be those pressure receptors are picking up more pressure, telling you that there's more volume than there may actually be when you get there. So there's probably not just one answer to that one.
Okay.
Yeah.
Good. All right. Well, let's talk about what we can do to improve continence. Like, I'm imagining if you're leaking wee, you want to probably wear a pad or whatever, but surely there's more as well.
Yeah. So our mainstay, whether you're pregnant or you're not pregnant, as far as urinary incontinence, is pelvic floor exercise. So there's really good, strong evidence around strengthening your pelvic floor. And like we were talking about before, the earlier we can start that in pregnancy, that puts us in a much better place. Now, if we're already leaking, then definitely we want to get you going on some strengthening. So strengthening, we need to, as we said, be doing some of those fast, some of those slow contractions. We need to be doing enough of them, and we need to be doing them with enough effort to strengthen that muscle.
And do we mainly, I always wondered whether we lie down to do them, sit down. Well, like what's the best postural position to be in?
Yeah, so I often say the position you're in at the time you remember to do them is the best position.
Yeah.
Yeah, so I think it's just getting those sets done.
And what do they say don't do pelvic floor exercises when you're physically doing a wee?
Yeah, so the reflex for voiding or for weeing, we talked about that detrusor muscle, would then also have a message that tells the pelvic floor to relax at the time. So I suppose if we're contracting a lot while we're trying to do a wee, we're just interfering with that reflex. We don't want to retain urine. We want to make sure we're fully emptying because, you know, there can be a risk of urinary infections if we're not getting that good flush through with every wee.
Yeah. Oh, this is so exciting. I love why do I like talking about wee so much? All right. So I want to move on to postpartum because I think there's a fear that people are going to be incontinent postpartum. Is it likely, let's say somebody's just had their baby the first day, second day, third day, do we all leak a little bit of wee?
Look, it is reasonably common in those early days when we think of the labour as well. So that's, a big event for the body and the muscles and the fascial tissue to go through. And there might be pain, there might be swelling in that area. So we do have to I suppose just be kind to ourselves and know that, there may be a little bit of urinary leakage during that time and that our body has an amazing capacity for recovery. So when we're thinking about, how long should it last, when should I seek help, some of those sorts of things. So we know women that have had more severe tears of the perineum, that we want to follow them up definitely early with the link and the risk to fecal incontinence. If we're getting some urinary incontinence that's gradually improving, then it doesn't necessarily mean you have to go out and seek a pelvic health physio. But if we're finding, we're getting to about 3 months and we're still bothered by that urinary incontinence, that's definitely probably a time I'd try and link in.
So really even at the 6-week postnatal check that you would expect it is still reasonable for somebody to be leaking a little bit of...
Well, I suppose when we look at our risks of urinary incontinence postnatal, we know that certainly postnatally that we're going to have women that do have urinary incontinence, but we want to see, I suppose, that improving. And if it's not improving, certainly come and seek help.
Yeah. And at that time, you're also talking to them about their bowel habits. Is there a link between urinary incontinence and fecal incontinence? Like if you're constipated, is it an issue?
There's a lot in that question.
Yeah, sorry.
I think for good pelvic health and function of that pelvic floor, we do discuss what's going on with the bladder, what's going on with the bowel. They might have questions about return to intercourse, those sorts of things. So we certainly may ask them about that, and then if they're wanting, some more advice and treatment with that, we'd certainly be helping them with that as well. Constipation, I suppose we then run that risk of straining. We know that fascia is still firming up and strengthening. So when we've got that fascial give, we again, through childbirth, some of us are at risk of vaginal prolapse. So that vaginal prolapse, what we're talking there is from the front, the bladder may press in towards the vagina, from the top, the uterus, and from behind, the bowel. So we're really wanting to avoid any strain, whether that's coming from straining on the toilet, heavy lifting, those sorts of things. So we're trying to screen and look at, giving good advice around that.
You mentioned heavy lifting. So how long, in that recovery time, what's the best course of action for someone in terms of return to exercise, return to perhaps their heavy lifting routine?
So broad guidelines, and we know what people's experiences have been with birth can be very different, but if we're looking at broad guidelines, hopefully when they've left that hospital, the physio's given them some guidance around some pelvic floor exercises, some gentle abdominal exercises to be starting with. So from that 6-week mark to 12-week mark, that's about progressively and gradually increasing your aerobic fitness and your strength as well. So we're looking at early days starting to walk and then picking up the pace a bit. What are those other gentle aerobic exercises that we can be doing? We're really, at this stage, our guidelines around running is not before 12 weeks, and then making sure that during that 6 to 12 weeks, we have progressively increased some of our strength training, not just the pelvic floor, but, the pelvic muscles, the leg muscles as well.
One of my most favourite sayings that you have is that you have to give yourself rest. And for me, that was duh. But you say horizontal rest. And I just wanted to say that in this episode, it's probably got nothing to do with incontinence, but like you say, it's got to be horizontal rest.
So I suppose when we've had those discussions, it's probably been more in that early phase, so that postnatal phase before that 6 weeks, to get load off the pelvic floor and the tissue there. So we can often, after delivery, we might feel what we call perineal heaviness, so a pressure down below. And that might be as the day goes on. It might be if we've had to do some heavy lifting or we've gone for a longer walk, those sorts of things. So when we've got those opportunities, if we've got our baby resting, is that an opportunity for us to lay down? Yes, it'd be great if we could have a little snooze and a rest, but is that a time, again, if you're catching up with a phone call or something else that you're doing, but can you do that sort of just laying down and taking a little bit of load off?
I love that, because sometimes you might just think, I'm just going to lounge on the couch now and do a bit of scrolling on my phone. But that now is translating that into, can you lie down on your couch and still do the scrolling on the phone if that's the thing that, you want to spend your time on? Yeah. I want to go back to the mode of delivery. So we've talked a little bit more perhaps on vaginal delivery, but what about Cesarean birth? Is that, am I still at risk for incontinence after birth?
Probably not in that immediate afterbirth. The other thing, I suppose, that we have with a cesarean is we may have a catheter in that, first 24 hours just to assist with emptying the bladder, so we're not getting in and out of bed. Sometimes that can have a few complications, which usually resolve fairly quickly. But I suppose over a lifetime, it's pregnancy as well that can have a risk with urinary incontinence. So definitely in that early phase, a cesarean may protect us, but over a lifetime there still is a risk of urinary incontinence for women.
I think what might be helpful for our listeners is if we could talk about what a typical visit to a pelvic floor physiotherapist would look like.
So I suppose if someone's coming to a pelvic health physio and they're seeking advice around their pelvic floor, or they've got symptoms from their bladder or the bowel, they could expect their physio to have a reasonable lengthy chat about what the problems are. And from there, then the physio is going to ask whether we can assess that pelvic floor. And we've got a few ways of assessing that. And I suppose our best information that we can gather would be an internal vaginal assessment. That's obviously quite a private thing, so it's really with consent, and it isn't the only way that we can gain information about that pelvic floor. So we sometimes might use a real-time ultrasound, so we can use that on the tummy or perineal to give information and a picture of what's happening, so that the client can actually see and get that feedback around the technique as well, which is important. Yeah, so we're going to want to assess it in some way so that then we can develop a program that's a little more tailored for that person to be strengthening appropriately.
And so they come for initial consultation and then a review?
Yeah, generally we would encourage a review so that we can, again, double check that you're still doing that contraction correctly, and then to be progressive. So like with any muscle in the body, it responds to demand. So we want to be gradually demanding over time that pelvic floor to be doing a little bit more.
And how good are people at doing their exercises?
It's hard. We're human and fitting them in. So it's trying to find ways to facilitate anybody to get that exercise done. So is it reminders on the phone? Is it linking early days when you're feeding and you're sitting? Is that a good time to do that? But we don't want to be doing it with every feed, because that's also a lovely time just to take
just
a pause as well. So it's trying to, work with the individual and find out what helps them as well to get those done.
I'm just going to say, for those that are perhaps lining up for their second or third baby listening to this, I found that when I had that letdown reflex when I was breastfeeding, that I would bleed more. And that would be the last thing that I'd be thinking, and contracting, and it was quite uncomfortable just in the early 2 weeks or 3 weeks after birth. And the last thing I'd be thinking about is my pelvic floor exercises
exactly.
at that time. Yeah.
So it may not be a great time for everyone.
All right. So I know that a lot of our listeners, and the average age of first birth is sort of increasing. So a lot of our listeners are 30s, late 30s, some early 40s. And it's unfair, but we come very quickly into menopause or perimenopause. So can we just help them out a little bit by talking about, what happens as we move towards menopause in terms of incontinence?
Yeah. So I suppose as we move towards menopause, that's where we're getting more fluctuations in our estrogen levels. And we know estrogen has a role in continence. So it also helps to keep our bladder calm, so the urgency side as well. So the blood flow, the health of the tissue in that area, our reduction in estrogen, that can affect that as well. Now, when we talk about, I suppose, pelvic floor strength, and I'm coining this from another physio, but I think it's a good way of explaining it, in that we start life, let's say, with a certain amount of pelvic floor strength, okay? And that's like, I suppose, a credit in the bank, okay? And if we do nothing but age, that pelvic floor strength will reduce, like other muscles in our body. But then we can have challenges in our lifetime where we're actually withdrawing from the bank, okay? So that might be a pregnancy, it might be a delivery, and then it might be menopause as well, which is the next challenge. So doing pelvic floor exercises, not only when you're pregnant or postnatal, but having them throughout our life, means that we're adding some credit back into that bank. We've got more resilience when that next challenge occurs, which may be as we approach menopause. So trying to encourage, that we do have a regular routine and maintenance of that pelvic floor.
Great advice. If you were to finish this podcast with a statement or a wish for women in terms of their pelvic floor health, what's something that you would hope for them to either recognise a symptom earlier or start exercise earlier or whatever? What do you hope?
I think, I suppose the main one is that to start exercising your pelvic floor now. Yeah, we don't have to wait until we've got symptoms, because a healthier pelvic floor, a fitter person is going to have less risk of urinary incontinence. So it's not just about strengthening your pelvic floor, it's trying to stay fit and healthy and exercising.
Seems to be the advice everybody
I
gives
know,
about everything.
exercise is medicine.
Yeah. Okay. Well, I want to finish with, those people that have come to see a physio and the physio has given them their program and then they've been pretty good and they've done maybe 60, 80% of the prescribed program. How quickly would they hope to see symptoms resolve?
Yeah, so we can look at it in that if they've started to do their pelvic floor exercises, they might get change even within a couple of weeks, which is more about learning how to activate it, using it more. So might be bracing with cough or sneeze or lift, so they're having less episodes of leakage. But we know from research we need to be doing at least 4 months of strengthening to improve the pelvic floor. But most of us are human and we don't stick to it 100% of the time. So we can expect that it's going to take us longer than that. Yeah.
All right. What happens if we've done that, or even people that you think they're never going to do that program? What's that person's next step to help them with their incontinence?
So I suppose going back to strengthening the pelvic floor, often, they're pretty boring just to sit there and do your pelvic floor exercises. So is there other tools that we can use to help you keep you on track and motivated with doing your exercises? There's biofeedback machines as well that we can use. Is there vaginal stims that can help that muscle contract? So we've got a few other, tricks in our toolkit. There's also supports that can be used to help with incontinence as well. So they might be little silicone supports that go vaginally that support that stress incontinence when there's a pressure coming down as well. So it's actually giving back wall support to the urethra. Now, if we're finding that these aren't helping or they're not acceptable to the patient as well, is that we'd certainly recommend referring on. So to your specialist, so it might be your gynaecologist, your gynae.
All right. Well, I'm really glad that we found time to talk about this because it is common. It's often not talked about. There's still a little bit of shame around incontinence. Maybe not a little, maybe a lot. People aren't wanting to talk about that with their other mates that are all happy with their babies, but it's something that does impact a lot of people.
Definitely. And I think the other thing is just with talking with women too is sometimes they don't recognise that they might have incontinence in the sense that they might avoid activities that cause that leakage. So if I was to ask, do you leak at all? They'd say no. And I'd say, well, what about if you're on the trampoline or going for a run? And they'd say, well, I don't do that, so I don't leak. So it's actually impacting their quality of life and the activities that they're participating or missing participating into. So it has quite broad ramifications for people.
Or even I know people who map the toilets if they're going out. Yeah. They know exactly where the toilet is in the shopping centre, or if they're doing a run or a walk or something, they know where the toilets are along the route.
There's actually, for those people that would like it, there is an app. It's the National Toilet Map. So that was a government initiative. So you would, if you've got your location on, it'll show you just in your vicinity where the toilets are, or you could put in the town name and it would show you if you're an unfamiliar place where those toilets might be. And, that's helpful even if you're toilet training your toddler to know exactly where there's a toilet as well.
Absolutely. Great. All right. Well, thank you so much, Belinda, for coming in today. It's been really informative and I'm sure our listeners will get tons out of this episode.
Thank you so much, Brigid. It's been fun.
Thank you, everyone, for joining us today on our incontinence episode. I hope that you share this with your friends and your family, and you can just quietly slip that as a DM to them instead of saying, hey, have you got incontinence? So they might appreciate just learning a little bit more about incontinence. As usual, if you love our episodes, we'd love it also if you gave us a 5-star review on whatever app you've listened to. And until next week, bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.